After yesterday.
Good morning, everybody. Being 9:01 on Wednesday, January 18th, I'd like to call to order the King County Public Health Committee. Clerk, please call the roll.
Juby,
Here.
Silva,
Silva is here.
Harver,
Carver here.
Williams,
Williams here.
Young,
Young here.
Sanchez,
Sanchez present.
Strathman,
Strathman here.
Pirog, Pepe.
Deputy here.
We have quorum.
Morning, everybody.
Good morning.
Thank you. I'd like to ask for unanimous approval of the minutes from December 21st, 2022.
Silva moved.
Thank you.
Young will second.
Thank you. Any discussion? Okay, and the December Public Health Committee financial reports are attached. And do we have any public comments this morning?
Uh-oh. Here we go. Perennial public comment.
And please state your name for us.
You, just calling up my information here. Yep. It's on. Good morning, Madam Chair and members of the committee. Name is Mark Avalar. live in Algonquin. I'm live in the 23rd district, and I'm also now the president of the Dundee Township Mental Health Board. I'm here this morning in order to communicate something that our board is tracking and Director Isaacson has been very helpful, and that has to do with the 2023 update of the Kane County needs assessment through the, hope I say this right, the Mobilizing Action for Planning and Partnerships Collaborative Projects. And I did communicate this to our board at our meeting last week that this project is kicked off or is formally kicked off. I'm sure Director Isaacson will have this as part of his update. And when you need input, whether in a primary research capacity or just simply as partners and collaborative partners for mental health, Dundee Township is ready to participate fully with the county because we know we cannot do this alone. There are so many components of mental health, and certainly the federal government, as I mentioned last month, that the legislative committee has seen that with the renewal of SAMHSA with a 61% increase in funding for the next 5 fiscal years of the federal government. And how do we work together to leverage bringing that kind of aid to Kane County-based agencies to work with Kane County patients in all areas where we could cover as a mental health board. So I bring this to you. I'm definitely keeping an eye, and hopefully Director Isaacson will have some terrific updates I can take back to Dundee Township. And I want to thank you for your time to allow me to speak this morning. Thank you.
Thank you, Mr. Avalar. We look forward to working with you. Thank you. Okay, next up, we'll turn it over to Mr. Isaacson.
Excellent. So I'll start with the general PowerPoint presentation just to share some high level statistics. First, a quick comment to what Mr. Avalar just mentioned. I think there's a lot of tremendous opportunity for us to work together with other local units of government as well as other organizations in the community. Our community health assessment that he referenced, that's something for the newer board members that we do every 3 years. So we will be doing that in 2023. And as we do that assessment, of course, we have a lot of latitude in how we conduct the assessment, and we have the ability to dig deeper in certain areas to get more information. So we've been in conversations about how do we really make sure, especially in communities that have 708 boards, that we can make sure we're providing them with the information that they need to make the best funding decisions at the local level too. So over the coming months, there'll be more information about that. Where we are right now is we're crafting a request for proposals so that we can choose a vendor who will help us collect that data for the different components of the assessment. So stay tuned for more on that. So starting with some basic highlights, just wanted to share a little bit with COVID statistics. As I referenced last month, over a 30-day period, we were averaging about 111 cases per day. And that's, again, the caveat. This is what's reported to the Kane County Health Department. So if you do a test at home, that doesn't get reported to us necessarily. So this is underestimation of the amount of COVID that's circulating in our community. Right now, over the past 30 days, we've been averaging about 95 cases per day. So we are seeing a decline. There's two charts in the packet here. And we have, Blair, this projector is not on. I don't know if you knew that. The chart is cut off across the top, which us public health data people really hate to do that. But because there was such a tremendous spike earlier in the year, if we do increase the chart to show the full spike, and I dropped it in just so you can see, and you'll get a copy of all the slides in the lower right corner, it makes everything else seem flat. So you can see in the bottom right corner, if we increase the chart, then all the other spikes really look like they're insignificant, when in fact they're not insignificant. But the good news is you can see with the red line, which is the 2-week average, our cases continue to go down. So that's good. We are seeing slight, well, I'll get to it here in a second. One note I want to make, though, there's talk of different variants and subvariants. That's always going to be conversation. There's always going to be talk about, well, does this spread more easily? Does this cause more serious disease? Those things I think are good tools for us to get people's attention. But the most important thing is, well, what are we going to do about it? And it's just human nature that we like to talk about a lot of these things. But if our actions are really the same, and I think a nice example is people may talk a lot about organic produce, but then they don't even eat produce, right? So same kind of thing. We talk a lot about, well, what's this new variant? What's this new subvariant? The main thing to do is for people to go out and get vaccinated, get the booster shots that are available. We only have about 20% uptake on the most recent booster. So we'd love to see more people out there getting their shots. But then also, if you or somebody in your family or that you work with has serious health conditions, wearing a face covering is something that's good to keep in mind. And I think one of the simplest things any of us can do that people seem to still not be really great at is stay home when you're sick. Nobody wants you at the party. Nobody wants you in the office when you're coughing and like telling people, oh, I have a fever and I sure feel crummy. Like, I don't want to hear you tell me that face to face. Just stay away. Of course, out in the real world, though, we do have issues where people may not have sick leave and things like that. So there's other public health things that we do have to be mindful of. If people don't get paid for not being at work, that puts pressure on people too. So we are aware of that. This is the chart that we've been sharing over the last few weeks that really looks at influenza-like illness in our 5 hospitals in Kane County. And the good news is it's a little harder to see now because the light blue line, which was the highest over on the left side of the slide when we had the big peak at the beginning of the year, has started to come down. So you can see as of the end of the calendar year, and it takes us a couple of weeks to get all this information put together, about 7.7% of ER visits were for influenza-like illness. So good news, COVID cases going down. RSV, which we've talked about over the last several months, cases have been going down, and influenza has been not showing up as much in our emergency department. So we'll continue to monitor this, but again, at least that's some good news. Just a little sneak peek here. One of the things when I took this job that we really want to do is improve how we're sharing information with you. So we're just about to release a new opioid report. So this is where, and I really want to hear from the board members as time goes on for what types of things would be most helpful for you. Certainly with Mr. Avalar and the Dundee Township conversations we've been having around mental health, we're looking at how do we provide people with that information that they need. So we have new information coming out that's analysis of our opioid overdoses, also with an eye to what are the risk factors that we want to look at. So these numbers we've looked at before. I'll just point out that over the last 10 years, the rate of fatal overdoses has doubled in our community and has been going up for the past several years.
And can I ask you a question about
Yeah,
opioids?
please.
I was listening to a program this morning about fentanyl.
Yeah.
Is that part of the opioid?
It is, yes, yeah, and I'll talk, and that's some of the information that we want to be able to get to people is more specific. So this slide, we've been sharing this type of information, which is just high level, but really working closely with the coroner's office to see when we do the lab work, what's in someone's system when they die, so that we can better identify it. And I'll get to another slide here that I think
Okay,
is
thank
even
you.
more striking along those lines. But fentanyl is most of the problem right now, absolutely. Looking at age comparison, and again, this is, I think, just one example as we start to dig a little bit deeper. So we talk about fatal overdoses, or for example, we may talk about suicides. Those are kind of the terminal outcomes that we see. But for communities to take action, we need more specific information. So I think this is interesting, just looking at these last 5 years or so, what age groups have been impacted. And what you'll notice here is that the 25 to 34-year-old has actually seen a pretty good decrease in the mortality rate, which is interesting. Bless you. But we also, that's still the highest rate out of any age group. But unfortunately, you can see every other age group, we've seen increases, including pretty dramatic increases. And this is from 2017 to 2021. You can see that for the 45 to 54-year-old, it's more than doubled that rate. And the 55 to 64-year-old, that rate has more than doubled. This is fatal overdoses. There's also more information that we're pulling together and starting to look at for non-fatal overdoses. So there may be younger people who are overdosing at higher rates, but they're surviving. So they're not showing up on a chart like this. But I think that's why it's information or why it's really important for us to be looking at this information from all different areas.
Thanks, Madam Chair. I got a question.
Yes, Ms. Gomes?
Well, actually a statement. I don't think it's fine. There are any final statistics on this yet, but I did discover through research that there is a correlation between folks are dying from fentanyl, which is not a prescription medication. Okay. So when there was regulations that took place around 10 years ago, that's when your overdoses increased because people were having less access to their prescribed medications. So then they went to the outside market. And that is in correlation with the age group. And I think we will continue to see that trend because that group of folks 10, 11 years ago were then suddenly cut off from their addiction. And then I think we'll see that trend. And it's an anomaly, but that was an interesting read for me.
That makes sense.
Absolutely. And as we look at this, and thank you to the board, just this month at the county board meeting, you voted to approve our grants to community partners. We're looking at a variety of things. And so this has to go with how do we prescribe medicine? So that includes, we had a physician who was on our opioid task force who talked about their daughter-in-law who was 105 pounds, et cetera, had some dental work done and had a massive opioid prescription. And we think, well, geez, now you've got all these pills that you have access to. So whether that person uses them, which again, appropriately using pain medication that's one thing, but having pills around either that we can inadvertently start to misuse and become dependent on, or that someone in the house can get access to. So if you have a young person or somebody who may already be struggling with opioids and they can access the pills. So we work with all different groups to help people dispose of their medications. We do the drop-offs. We also have a couple of different types of things where you can, one brand name is called Dispose RX, where you can actually pour some powder in and it forms a gel so that people can throw out their opioids if they have them. But from prescribing for pain on through, and that's why heroin jumped up, as Ms. Gomes was saying, that it was so cheap for people who couldn't get their prescription medication any longer. People were turning to the street to get some of these things. Now, as Madam Chair mentioned it, we have fentanyl showing up in things that we didn't even know about. So one more slide I'll share. And again, this is just kind of a sneak peek. We'll have the full report that you can dig into as much as you want. This is looking at deaths by drug combination. And what we're seeing here is the red is heroin and fentanyl, which again, fentanyl is manufactured, most of it is manufactured in China, comes in through Mexico. It's incredibly cheap to produce. And you've probably seen some of the slides where very small amounts of it can be lethal, but it's something that people can use to cut drugs to really stretch them so that they're making more money. In 2017, you'll notice there's a little asterisk there where because the number's under 10, they suppress that value. That's just something kind of common with smaller numbers like this. But what you'll notice is the red line starting in 2018, which again is heroin and fentanyl, has been going down over the past few years. And the blue line, which is cocaine and fentanyl, has started to uptick where it's actually doubled in 2021. And why this is problematic is people who may use heroin may be more familiar with fentanyl. They may know and expect that fentanyl is going to be in their drug supply. But now we have people who are taking pills and people who are using cocaine that aren't expecting fentanyl to be in their drugs. And so they have zero tolerance. Fentanyl is just so strong. And so we're seeing a lot of deaths again, where a lot of people who recover in the emergency department, they report that they don't use opioids. And they say, well, you just overdosed from an opioid, and they're caught by surprise. So again, in the most simplistic of terms, we could say people shouldn't be using these drugs. These are illegal. You shouldn't use them. And that's fine to say, but we also know large numbers of people are using these, whether it's just recreational use. And this is a case where somebody, and I talked about it several months ago, I think at, I can't remember if it was at the Naval Academy where there was an overdose, where multiple people overdosed. They didn't know they had fentanyl. And I think somebody thought it was cocaine or something. So these weren't people who were regular active drug users, but they were exposed and ended up overdosing. So it's something that this is a threat in all different segments of our community. As we see with the ages, it's not just young people. It's not just older people. This is something that really crosses economics, it crosses ages. So it's something that we need a lot of different types of interventions.
Madam Bates,
If I
Mike,
were-
please.
Bates, please. If I were a drug dealer, I would not want my customers to die. So why are they putting fentanyl into the cocaine? Is it?
Yeah, it's interesting. And we've talked about this a bit, and this certainly isn't my area of expertise, but in talking to law enforcement, we've talked about this. It is a way, because fentanyl is so powerful that you can cut this. And if you think of, I make more money based on more product that I sell. So if I find a way to stretch that product to make even more money, that's really why I'm selling
The
drugs.
fentanyl is so much cheaper to
Right,
make.
right.
Okay. Thank you.
And
Yes, Ms. Lewis.
And I also think our local drug dealers,
Mike, please.
they don't, oh, I'm sorry. Lewis, our local drug dealers don't know where it's coming from because they're getting it way up the supply chain, just
They
like
don't know if
anything else.
there's fentanyl in it or not.
But I read an article, and I wish I remember where it was from, that they're actually becoming readily available, things that you can test your drugs
Yes.
to see if there's fentanyl in it, which is kind of a sad state, but now they're saying everybody should have Narcan in their glove compartment and in their home.
Right.
Narcan's the agent that, reverses the effects of the heroin. And now they're saying that, they're going to start widely distributing this, that you can test your drugs for fentanyl, which is a good thing, but it's also a sad state on society.
It is, but it is our reality. And unfortunately, unfortunately, board members who've been touched by this and community members that we interact with, again, from all walks of life, it's unfortunate. But then you think, okay, if my son or my daughter could still be here with us because we'd had access to this thing before, that's the kind of thing I think where we need to be a little more proactive. There just was a law that came into existence that went into effect on January 1st here in Illinois that makes it a little easier to prescribe fentanyl test strips. It's still a bit of an off-label use because they're really meant to be like dipsticks for drug testing people. So it's meant for urine, but they work for people to test their drug supply. It still needs to be a medical provider who's doing that, a pharmacist or a clinician. So the health department does have grant funding where we work with community partners to make fentanyl test strips available. We currently are not individually providing them to people, but we are helping to support that in the community. I've got a flyer I'll show in just a moment for some of the work we're doing with the street outreach team at AID, the Association for Individual Development. But yeah, I think the main takeaway from this is it just is going to take a lot of different interventions. So.
Ms. Combs.
Just to touch on that, what Ms. Bates said, I think it was a month or two ago, we did discuss, we have to think outside of the box as it comes to messaging, having sat down with our local drug dealers and explaining to them that they can be charged with homicide now. And we are starting to charge those drug-induced homicides, which, having a conversation with a local drug dealer is not something that we're all accustomed to. However, we cannot leave them out of the conversation because they are directly responsible for those deaths. So when we tell them, and when I have I have had several conversations with them, it's the onerous, and you have the ability as a drug dealer. Now, I'm not promoting this. I'm just saying this, they can't be left out of the conversation. You know that you have a bad batch of fentanyl within hours. I mean, we have people dropping within hours from when they get their batch out. And they can recall that batch. They have the ability. They're an organization. So asking those folks to do this is not a horrible ask. And it should be part of our message as well. We can't leave them out of the message because they're part of the solution. Unfortunately, we'll never stop them from, I don't think we'll ever stop them from being out there. But, they're interesting conversations and thought-provoking to the other side when you see the wheels turning in their brain. They're like, well, yeah, I guess I can do that. Yeah, you can. 'Cause
Is
you
the
have kids
fentanyl
too.
testing strips a solution or something that should be part of that conversation
Sure.
with the drug dealers?
I mean, they're not readily available to come in here and sit down and have a conversation, but,
No.
I've spoken to Mr. Isaacson and, I'm massaging that just to allow more conversation, more people to be included in that conversation, which is tricky.
The program I was listening to this morning said that fentanyl was 90 times more potent than heroin. That's really potent.
Yeah, there was a graphic that went around a few years ago that showed like the grains and here's how much heroin can kill you. And then, here's how much fentanyl can kill you. And yeah, it's incredibly potent, definitely.
So I'm thinking that there's soon going to be a black market for testing strips.
I think
Right?
Madam
Ms.
Chair.
Bates?
To step back to the root of the problem, some people call overdose and suicide deaths of despair. And I know you know this even better than I do, but I want to go to the root of the problem, which may be food insecurity, jobs, hopelessness. And I know you're working on all of those, but
Yeah, I think going upstream on those things. So certainly we have, especially with the opioids, many affluent families who it looks like everything is going very, very well from the outside. But if people are struggling and we do, I don't believe I included it in the slideshow today. But over the past 4 years, we continue to see St. Charles have the highest fatal overdose rate. When we've looked at the data before, we see the highest suicide rate. So there's a couple different things, and this is something I try to point out when we talk about mental health as well. We have disparities. We have, as I mentioned, people can't stay home when they're sick because they don't have paid sick time. We have those kind of pressures. We don't have equal access to healthcare. We have poverty. We have racism. We have unequal access to all kinds of different services. We have a lot of people who have experienced trauma earlier in their lives, which the data on that is incredibly clear about the risk that puts people at for, and you said like deaths of despair, but for self-medication and for risky behavior later in life. So this is something that we're going to continue to focus on. And a big part of this opioid report is really looking at what are some of those risk factors. And we need to be aware that there's other things, especially in the opioids, that I may be affluent. I may be on my way to an Ivy League school. I had an injury, had a prescription, and ended up on the path to having a substance use disorder. That can happen too. But for most people, it's all these other social factors. And in public health, we talk about social determinants of health, really place, your zip code dictates your health more than anything else. So more than health decisions and things like that. And I'm a big believer in personal responsibility. And the data also shows that, you know, if you take the same person and drop them into a couple different environments, we know how that's going to impact people's choices. So we want to hold people responsible, and we want to give people the resources to be successful. But based on what happens to people early in life, there's much more likelihood. And this is not just for substance use, but this is for obesity, for diabetes, for all kinds of things, that there's a direct correlation between childhood trauma and these other negative impacts that we'll see. So we'll talk much more about that. This report is going to have a section on that, and actually probably the next report we put out, because we're going to want to put a series of these out, is really going to focus on more of those things. Because whatever we're talking about, I think if we go upstream, we'll find a lot of the common
Thank you.
things.
Thank
Very
you.
good point. Ms. Lewis.
Yeah, so not to belabor it all, but he's right about the zip codes. And like, I live in Aurora, and I think people are way more aware of fentanyl and all these kind of things because we kind of come to expect it in Aurora because we live in Aurora. Okay, I had a nephew that you all know this a year ago that died of a fentanyl overdose, and he lived in a good zip code, you know, and he lived in a nice house, and he had a wife, and they both had nice jobs, and they both had college educations.
Sorry.
And when the toxicology report came back that it was fentanyl overdose, we were in shock because that we didn't see it coming. And I think that's what happens in like St. Charles and these things, because they're more affluent, because we have more money, we don't have the awareness as much, you know, as in areas where you kind of expect more drugs to be. But unfortunately, fentanyl isn't just a poverty issue. It's, you don't know that it's in things. So.
Mr. Young, I see you have your hand up.
I do. Thank you. David Young. Looking at this chart, you're talking about cocaine and heroin. Are those drugs still considered to be illegal in our county?
Absolutely, yes.
So the drug dealers that you know and the people know that are dealing these drugs, why aren't they imprisoned?
Yeah, I can't speak to that.
Okay, because that could be one solution to get the drugs off the streets, is to imprison the drug dealers. And if people know these drug dealers, then they need to turn them into the police. I mean, if this is killing people, then and everything's coming up through Mexico, and the drug dealers have their mules through Mexico, then you need to stop the trail. And no one's talking about that. You need to stop that and throw them in prison.
And I think there's a lot of work that goes into that. And we've worked with the DEA, and we certainly work with local law enforcement. And so there's really, like I said, there's multiple angles to this. So I think the points that you raise are good. And we've also seen that we have been completely unsuccessful in trying to police our way out of substance use issues. And that's before fentanyl, unfortunately, where we're locking people up. We know then, back to Ms. Bates' comments, one type of trauma is loss of a parent. And so if your parent gets locked up because they're dealing drugs, well, now we know, and this is the public health side of things, and I can't speak with expertise on the law enforcement side of things, but on the public health side of things, without a doubt, we know we've just put that child at greater risk that they're going to use drugs later because we locked their parent up. And I'm not saying that we shouldn't put people in jail for offenses. I'm not trying to make that argument at all. But we do know in our communities where we're arresting more people, that we're putting more pressure on younger generations. And frequently when we talk about these things, and it's exactly what Ms. Bates said, you know, I'm interested, okay, for the baby that hasn't even been conceived yet, for the baby that's going to be born 2 years from now, we can predict with a pretty high level of certainty what types of things they're going to be at risk for based on what they look like, where they live, what's happening to them in their environment. And so that's one issue that we have with trying to police this. And I think things like our pre-arrest diversion program that the state's attorney's office runs, I think the things that the sheriff's office does with treatment within the jail. And again, you get into philosophy of, is this punishment, is this rehabilitation, et cetera. But if our goal is, we don't want people in our community dying, and we don't want people, we want fewer people dealing drugs, then I think we need to figure out ways to get people less dependent on drugs. But it's certainly a complex issue, and fentanyl, because it's small and it's pretty easy to transport. And when we look at the shipping containers, for example, that come into this country from China, when we look at how easy it is coming across any of our borders, Canada or Mexico, there's a lot of money that goes into trying to stop it, but it's just really easy to transport fentanyl specifically.
I think our conversation this morning shows how complex.
It's very
this
complex.
issue is.
Madam Chair,
Yes, Ms.
Madam
Molina.
Chair, Dr. Silva.
Oh, Dr. Silva, yes.
Yeah, I'm not sure if Ms. Molina's on the call or not. Thank you. Good morning. So just a couple of things. My 2 cents worth, my insight, and I think it's everybody pretty much has the same question. Why don't we get rid of the folks that are doing this sort of thing? And my sense in King County is that we are doing a phenomenal job of tracking down folks who are doing this sort of thing and arresting and preempting deliveries, because I just read that there was an arrest. And so I see that often, and I've heard, my years on the board have, I've heard a lot of the arrests. I'm wondering if part of the issue is prosecution. And that's not to say that we don't have phenomenal prosecutors. What is to say is what we can do. I think we have to take a step back and look at what we can do as legislators and as a board, and how can we strengthen our prosecutors and also our defense attorneys, because it is a balance of justice. So I think that's one thing that we can do. The other thing that we can do is really look at how important mental health counseling is, because mental health counseling is an intervention that's so personal, and it gives people the opportunity to really get their questions answered and guidance in their specific problems, instead of just a general of what's going on in the world. Each of us has our own individual circumstances that we're dealing, our own sets of adverse childhood events, our own sets of circumstances that prevent us from being fully functional at times. And then beyond that, people can be fully functional and still be extremely depressed. So I think it's part of it is identification and is awareness, and also looking at what can we do, what's within our grasp that we can do as individuals and as a board in whole. And I think those two things support our prosecution and thereby our defense attorneys. And also, how can we provide more funding? How can we provide more access to individual counseling for the folks that are actually seeking it? Thank you.
Thank you. Those are some very good points. And I think, again, that just shows how complex this issue is and how many fingers it reaches into different parts of our administration for the county.
Madam Chair, Gums.
Yes. Ms.
I
Gums.
just want to clarify something to Mr. Young's point. Having spent my life in law enforcement, there's no drug dealer on the planet that's going to admit to you that they're a drug dealer, but I'm a little sassy, so, I can call them out. There's a difference between knowing somebody is a drug dealer and proving that they're a drug dealer. This is an organization. They're not dumb. They know how to work things. I applaud our law enforcement, our prosecutors. They work diligently with the federal government on a daily basis to do the best they can. But it's one thing to know somebody's a drug dealer. It's another thing to prove that they're a drug dealer. And part of our messaging also is, which I message to my constituents, is if you know that your neighbor's a drug dealer, call the police. And they do that. So back in the late 90s, we had a huge effort to get people to call in the things that they knew were going on. And that was effective. It was effective for many years. So we just have to message that out. But I just wanted to point that fact out, that I'd be glad to turn him in if he just admitted.
Thank you. Okay, I think we showed that this is a complex issue and we're not going to
Much
solve
more
it
to
this
come.
morning, but
Definitely.
continue.
Just one positive thing that we have going on. This is just a table from our draft report. But in the second column, you can see the number of people who we have received reports that they've been administered naloxone that we provide. So as was mentioned, we want naloxone. Unfortunately, we want naloxone to be as readily available like as AED machines, where you can save people from a heart attack. Unfortunately, we want to be able to, we're in a position where we want this readily available. So the health department has naloxone that we can make available to people. You can see in 2022, we have 86 partner organizations that we're working with that we distribute naloxone to. In 2022, we had 123 overdoses reported to us. And out of those, 106 people survived because they were administered naloxone that we provided as part of this program. Just like with the COVID tests and what's reported, most of the naloxone that's used isn't reported to us. We're pushing this out here like wild. We have forms that we ask police departments and EMS to fill in and report to us, but the vast majority of people aren't. So we know at least 106 people were saved last year, but that's just a small fragment of the people who've been saved. And again, and I think this is where it gets tricky with the tough philosophical argument about it. We have loved ones that, and I unfortunately work with a lot of people who've lost mostly their children to overdoses. So no matter what we think, those people wish that their child was still alive, right? Those people will say, well, if we had this 10 years ago, would my child still be alive? Would Christmas look different? Would Thanksgiving look different because they would have lived the life that we thought they were going to be able to live? So we've distributed over 9,500 doses of naloxone, directly trained over 1,000 people. And we want to just keep pushing those numbers to get more naloxone out into the community.
One more comment, Ms.
Short
Bates?
question, short answer, I hope. So you keep saying naloxone and the slide says Narcan. Are they identical?
Microphone, please.
Yeah, so the question is Narcan versus naloxone. So naloxone is the medication and Narcan is the brand.
Oh,
you.
okay.
I
Short
typically
answer.
say naloxone, but
I say Narcan.
yeah, and what we give out is Narcan. But just in case there's a cheaper version, I just don't want to have to change my language later.
Okay.
So switching up just a couple of things. Here's some harm reduction events that are going on, just pop-up events that one of our partner organizations, AID, is engaged in. So again, they're providing fentanyl test strips, naloxone, some of the safer supplies for people. And again, this gets to be touchy to people, I think, politically and philosophically, but it does save lives. It is a proven intervention. So we work closely with AID to do some of these things. And then a couple of things that we have coming up, changing from the naloxone for Heart Month, I should say. The health department is working closely with the sheriff's office and with Sherman Hospital, and we want to train as many people in CPR as we can. So you should have seen through your email information for this. So we're excited to have registration going quite well. This is for both the public and for county employees. Over on the right, and this is something that we'll talk more about in the coming months, but one component of our children's mental health initiative, and this is just kind of a theme for all of our work, but having that community voice. So when we talk about youth mental health, one important thing is we need parent voice, we need family voice, but we also need youth voice. So this is our 4th annual Youth Voices Forum. We have brought kids together from all over Kane County to talk about mental health issues, to talk about what resources they think are needed. Something that was just introduced is having a public facing panel. So there's going to be a component where it's in person, where the young people can get together and they can talk. This is done with the social workers and psychologists from their schools. So it's really strengthening our network for everybody. But it's really important for us to hear directly from young people what they're facing and what they perceive as their challenges. But this piece here, and we'll send this separately on February 9th, this is something that you all can tune into. where you'll be able to hear young people and professionals talking. Last year was very successful. Again, with COVID, we've done in person, we've switched to remote. Now we're excited to go back to in person, but we will have this remote opportunity, and it's pretty striking to hear directly from young people what it is that they're struggling with.
And with it being people from their school.
Yeah.
Excuse me, it's not a stranger that they're speaking. to.
Exactly, right,
Right.
right. And yeah, so we want youth voice, but this is controlled in the sense that we work with the school districts to help identify kids. We're not just putting a kid out there to air their own issues without it being in a supportive environment. So very exciting that this is coming up. And then finally, I always like to introduce our new team members. So certainly recruiting and retention has been something that I think every organization in the country is struggling with right now. So thrilled that we have four new team members. And the kind of bookending, we have Raylyn and William, who've joined our environmental health group and are going to be sanitarians. So we've been able to successfully hire several new sanitarians over the past few months. And then we have Sue and Monel in the middle, our two new nurses who have joined our team. So again, knock on wood, over the last 6 months or so, we've been able to bring on, I think, some pretty good people. And we've had one retirement. We just lost one part-time person who took a full-time job with the sheriff's office. So we hate to see her go, but we're glad that she has that opportunity. And then the only person that I think we really lost was somebody who lived in Rockford and is changed and is staying up there. So so far recruiting and retention have been going pretty well. So we're really excited about that. And again, we have such an awesome team at the health department. The great people are what enable us to do all of the things that we talk about. So we want to bring people in and have a chance to let people talk about their different programs. I think especially for new board members, that's an exciting way for you to see how things are going. So after my presentation, and I'll be happy to introduce our next guest for the next agenda item.
Any questions before we go on?
I have one really quick question, and I hate to put you on the spot.
Okay.
But going forward, most of us saw the news last night of the toddler spinning the gun. Are we partnering with the sheriff's department to provide gun safety locks? Do we do that?
We don't formally do that, but I'll call him after this meeting and we can have that.
Very good.
Yeah,
Thank you.
excellent idea.
It came to my mind because of the news. So thank you.
And we are involved in the gun violence prevention work, but we haven't been doing the safety logs, but that's excellent.
That is a good idea.
So maybe Blair, if we can switch presentations, and one thing that we've talked about over the last couple of years is the IRIS electronic referral system. I mentioned we have a great team at the health department. I'll introduce Kim Peterson here in a moment. Kim has been started with the health department just before COVID, has a clinical psychology background and is just working on her second master's degree, brings a wealth of experience in connecting families. We promoted her over the summer. So not only is she managing our early childhood network, but now she's also managing our program where we have a couple of people who are providing interventions in early childcare settings. And then she's been the lead on promoting and maintaining and training and really pushing out our IRIS electronic referral system. This is an amazing tool. So I think you're going to enjoy hearing Kim tell you a little more about it. So thanks, Kim.
And Kim, if I can excuse you for just 1 minute. Excuse me, Mr. Tarver, did you have a question before we move on?
Not so much a question, but a statement. I just want to express my extreme gratitude, Mr. Isaacson, and everything that you are doing and your department. The work is overwhelming, and being from the clinical side here, working in the public education system as a social worker, I can attest to everything that you've talked about today, and Dr. Silva, all the comments that you mentioned, and just have so much gratitude for the work that you are doing and are doing. And I want you to know that you have our full support, or at least my support going forward in all of your initiatives. And I just wanted to make that known. So thank you so much.
Thank you.
Very well spoken. Thank you. Now, Ms. Peterson.
Thank you.
As Michael said, I'm Kim Peterson and I'm.
If you could get a little closer to the mic.
Sure.
Perfect.
Don't want to be too loud. I'm the supervisor of early childhood programs at the King County Health Department, and I wear a lot of different hats. But today I am going to talk to you guys about IRIS. Now I know Leslie and some other folks know about IRIS. I presented maybe a year ago now, just a little bit about it. So I'm going to give you an update. This is an electronic online referral system that's fully HIPAA compliant. And we rolled this out in March of 2021. And so it's been about almost 2 years now. And we'll just go through some data and update you on some things, and then we'll leave some time for questions. Can you possibly click on that link and play the short 1-minute video? There's a short little video kind of going over the referral system.
IRIS is a web-based communication tool that helps organizations connect families to the right resources in their community. IRIS helps coordinate services for families by linking your community's service agencies and organizations with a shared communication tool. IRIS is simple, mobile, and customizable. Here's how it works. A family's information is entered into our HIPAA-compliant system. A partner agency is selected and the referral is sent. As referrals are rejected, accepted, and completed, both referring and partner agencies are kept in the loop through email notifications. Organizations can indicate their own capacity, allowing referring agencies to make informed choices. Families are provided with a clear path between different community services and are connected to the services that meet their needs. Providers save time through streamlined communications and can efficiently track all the referrals in one place. Communities gain a wealth of information to help drive data-driven decision-making and guide resource allocation. IRIS, helping families thrive through connected communities. Contact us today to discuss your needs and to see if IRIS is a fit for your community.
So as you can see, this is a comprehensive tool that was developed by the University of Kansas. We can accredit the grant funders for the AOK network and Michael for bringing this tool to the county. And then what we did was, as we saw interest for this, the way we were doing referrals before was reportedly very disorganized. Folks were not able to track kind of what they were doing and showing all the work to their funders. Referrals are a lot of work. There's a lot of follow-up. There's not a lot of feedback on what happens with that referral. So we set out to really improve this system to wrap the families in care. You know, you're here with me. What do you need? What else do you need? If I can't provide this for you, how can I help you within our wide array of amazing services here in this county? How are we going to connect them? So we really did a lot of work on the front end with engaging stakeholders and gathering together a large group to launch this. We launched with about 60 partner organizations, and now we're up to 150, which you'll see later. We started with our vision. You know, our overall large vision is to have safe, healthy, and productive communities for all. And when you guys were talking about the opioid issues and board member Bates brought up diseases of despair, I think from a clinical psychology background, we really look at these kind of things and say, what are evidence-based solutions to these kind of diseases of despair? It's so complex. And referrals are one of those things. If we can meet folks all their needs in an easy way and remove some of those barriers for them, they'll be less likely to have substance use disorders, to seek comfort in ways that are, you know, illegal or harmful to them. if we prevent those types of diseases of despair, we can really make progress in that way and kind of eliminate those unnecessary deaths and different things like that. So the large vision was the Kane County Iris community will build upon strong collaborative relationships with partners to implement a data-driven, comprehensive, closed-loop referral system that identifies gaps in resources so that community members will be more effectively connected with the services they need to support positive outcomes. Now, that's a really big run-on sentence, but it kind of encapsulates everything that the system has been doing for us. Oops. So this slide just tells a little bit about the story, how we launched it and what we did and what our vision was. And I'll share this presentation with you so you can read over it if you're interested. When we talk about growth of the system, we at first saw a huge spike in growth in the beginning, you know, when we launched with our 66 community partners back in March of 2021. And then at our annual celebration in 2022 in March, we were up to 110 community organizations, and we were at about 1,512 referrals. So basically, we were really happy with that, and all of our partners were really happy with that. And then come October, we jumped up to 3,457 referrals. That just means, you know, more folks are utilizing the system to connect those individuals and families with the services they need throughout the community. Now, I just ran the data yesterday. So as of yesterday, 2023, we have 150 community organizations participating in 4,468 referrals. Wow. We're very happy with this. Thank you. We're really happy with the steady growth, and we're constantly working on continuous quality improvement on this tool to get feedback from the end users about how can we make this better? How can we make this easier? We're really trying to make it easier for the staff to make these referrals, to follow up with these referrals, and not let these individuals and families fall through the cracks. So back at our annual meeting prior to that, we administered a survey to get the input from all of our users. At that time, there were over 700 users. Now there's over 1,000, and we'll be ready to launch that survey again in the next 2 months to get the updated feedback. But these are some of the things that folks were saying in the survey results. Ease of use. They love how easy the system is to use and the transparency of the follow-up. So part of the system is there is that feedback loop completion. When you send the referral, the partner responds back whether they're going to accept or reject that referral. And then they make the step to call the individual or family, enroll them in services. And then the end result is communicated back to the initial partner saying, yes, this person was enrolled. Maybe they were unable to contact them. There's other reasons why they maybe didn't complete the referral. But the point is that that person that referred gets that information back. And if they're, let's say, their behavioral health provider, they'll continue to see them and say, you know, what happened with this referral? Was it too far? You know, maybe their car broke down and it was a transportation issue. So let's go back into the system and look for telehealth options or other options where we can still serve you, but remove those barriers to service that folks may have had previously and wouldn't have communicated in the past. And folks are saying, you know, there's easier linkage, especially after a wide breadth of partners were added. How we encourage engagement in the system is our current partners will say, you know, I refer to this agency XYZ all the time. Can you please reach out to them and engage them in Iris? And that's how we have gotten the majority of our partners. Word of mouth and those folks just really connecting us, which is nice. And the ability to connect families to services has become easier, more efficient. As you can see, the efficient workflow comments talk about sending a referral directly improves the likelihood that the client will access the services. So before we used to send out these guides, and my group makes these guides, so I do love them. But sometimes it's really hard when you're going through multiple crises or diseases of despair to, even if someone circles where you should call, to really do that on your own when you're going through a lot of things is very difficult. And then what happens when you call and they say there's a 6-month waiting list? How devastating, you know, and then they don't know where to go next. So it's not, you know, we're really kind of helping folks, giving them a leg up to connect directly with the services. Patients have been able to receive services faster and there's a quicker turnaround. And then the partner communication, which we all know any success to any project is communication. And this has increased greatly where this is a HIPAA compliant tool that we can communicate directly through the system, partner to partner, and include personally identifying information if we need to. And it just makes things a lot more quick and personal, and it really is solutions focused. And we're happy to report that our average initial response time is only 91.6 hours. So that is the average, and that is really great for a referral turnaround. And we track that at different points at quarterly. And then this was just something that one of our partners reached out to us to give us some positive feedback. And they said, I sent a referral through IRIS for an adult today to AID at 10:48 a.m. And they received a message back at 11:14 a.m. that they had accepted the referral and the individual is scheduled for an intake appointment already. You know, as you can see, that is amazing, and how great for that person to feel that relief. I mean, how many of us have waited on hold or even tried to just even figure out where we can call through our insurance or what have you? So it's really helping our partners with their workflow and our community members. We decided to do a cross-sector approach. The IRIS tool is spreading throughout the state and the nation. It was, again, developed in Kansas, but it is spreading all over Illinois. I think last I heard there was 30 different communities using IRIS, but we did a cross-sector approach. We're including substance use providers, behavioral health, primary care, parenting support, career development, all those social determinants of health, you know, housing and utilities assistance that will really bolster people up and give them the tools they need to succeed and be productive members of society. And again, transparent capacity and communication. This is something that is very hard in this sector. If you've never worked in social work or in this area, it's really hard to do this. And the great thing about IRIS over other referral tools is the capacity bars and the system is updated by the folks that are working there themselves. It's not a database administrator. I'm not going around calling. It's those people that are working there and know the real capacity. You know, if they're at the red and they say they have no capacity, they'll put something like wait list for Spanish services is 9 months, wait list for English is 6 months. So that provider referring will know to at least tell their client, you're going to be expecting a waiting list. Would you like to still go there, or can we look somewhere else that maybe has less of a waiting list? Again, eliminating barriers. And like I said, partners can engage in HIPAA compliant communication directly through the system. You know, my second master's degree right now that I'm getting is in data analytics. And so I'm loving this. It's data made easy. In this data-driven world, we're looking at funders, we're looking at multiple streams of funding, we're looking at grants and everyone, you know, 150 organizations, all funded by a variety of folks. But what we can do is pull organizational level data and community level data right from the system. And it prints out in an Excel format. You can manipulate it. You can run your reports, do your pivot tables, all that kind of thing. And it helps the organizations themselves set goals for their team. Like, we want to send this many referrals, or we want to connect this many people to other services, and then have accountability for those goals by running the data reports and then setting new goals. Grant reporting, like I said, all of our grant funders are more and more leaning towards data-driven decision-making, which is amazing. You know, don't just do what we think we should do. We need to look at what the data is telling us. Funding requests, this actually happened. Two Rivers Head Start, the community service block grant, used the data from IRIS to show that they had more need out in the community than they could meet. And they were successful in receiving new funding, increased funding to meet these needs out in the community. So that's a success story. Outreach initiatives, there's a lot of outreach individuals employed at all of these organizations that have goals around partnering with other community organizations. And this helps them connect in an organic way throughout the system. And as turnover happens, we've seen that this really increases the likelihood that those new staff will continue those partnerships with that their predecessor had throughout just sending these referrals. And then you get to know that person and then that organization. For community level data, we have quarterly meetings. You guys are all invited to attend via Zoom, where we update folks on de-identified community level data as far as participation and the need capacity ratio of our community. Like I said, we have a lot of great organizations, but there is a lot of need as well. Housing and utilities is one huge one we're seeing where we cannot meet those needs very well. We can drill down to hyperlocal data. This is so hard for us public health and other fields to get that zip code level data to show where does funding really need to go. You know, should these organizations be located? Where should the services be easier to access based on zip code level data for referrals? Data-driven decision-making, like I just mentioned, it's very important to stick to the facts and look at where do we need to make improvements exactly. We need more behavioral health organizations that take Medicaid, for example. We need more sliding fee scales, and the need for mental health services right now is outweighing the community capacity at this point. Continuous quality improvement. This is another thing I love about the system. We can continue to drill down, looking at the data about participation, how long people are taking to respond, what are the outcomes of enrollment versus not enrolled, and different things like that. And also user experience, end user experience, customer experience to really drive how we move forward with this tool. And this is just the last part. It's so easy to become an IRIS partner. For those, when you're out in the community, if you talk to folks that are the heads of organizations or supervisors, or especially the school districts, talk about how it's free, how the health department is paying for it for all of our organizations. Talk about how they'll have access to over 150 local community serving organizations to connect their clients with and to help them meet their outcomes. And all they would have to do is email one of our community managers, and then we provide an IRIS demo and information session. We even do trainings for different staff. And then they just have to complete one piece of paperwork and sign a data security agreement. So it's super easy, and we take them through the whole process. We just had West Aurora School District join for all their student support services, including school nurses, school psychologists, school social workers. And they were just so happy. It's just sometimes getting to that administrative level to understand and recognize the kind of benefits of the tool and how much easier this makes the life of the staff person who has their boots on the ground. So that's all I have for you today as an update. Again, we have a community meeting coming up, and feel free to always email me if you have questions or like updates or anything like that. So thank you.
Do we have any questions for Ms. Peterson?
Yeah.
Ms.
How are
Lewis?
you? I just want to let everybody know, last year when they implemented this, there is a video. So if any of you want to see the IRIS system, it's on the health department website.
Yes.
And it's a short informational. It's actually really cool because it shows like how you click on it, how you get to the things. And secondly, whenever I'm out and about in the community and I talk to people, and I ask them, you know, providers, I'm like, are you in IRIS? And they're like, yes, it's great. And I'm like, good. So
thank you.
and
Good
if East
ambassador.
Aurora is not in, let me know because I'm going to actually be there tomorrow.
They actually are not. There's one program that is, but I just presented at their professional development day on ACEs. Funny enough, the adverse childhood experiences, and they showed a lot of interest in the IRIS system. But again, it takes all of us to kind of get up to that administrative level, because people that aren't doing the work don't always understand why it would be a necessary thing.
I'll harass them too. And then when they hear it from multiple sides, maybe, because it's important. We have so many, especially like our counselors, And we have like CVAC and all those kind of, what they call them, trackers now.
CVAC is on Iris.
Okay,
That's the
yeah.
only one.
Because that's what we do a lot. They go to them and they say, we got this kid and they can't wait for 6 months. They'll have just gotten out of like Mercy or something. They can't wait 6 months to get into counseling. And so then they plug in and just keep going until they find somebody that will see them. Because especially with a high school kid or a family, if you don't get them the help right away while it's fresh in their mind, they're not going to do it, because there's so much stigma anyway. So you guys are doing so great of a job.
Thank you so much for your support.
Ms. Bates.
Do you have any, Bates, do you have any data yet about mental health capacity, what'd you call it, ratio?
Yes. The thing is that we have, a small team working on this and we have a ton of data. So I hope in the future we can expand our contract with Kansas to have them like really dive into the data and pull out the most important things. But we do have kind of like high level data on that. And like I said, the needs are overreaching our capacity at this point.
Okay. So is that something the county has to help you with, expand this contract?
Yeah, it's something we're working on and we want to build our internal capacity too. And then we always struggle because Kane County has a decentralized, especially with behavioral health system, then accessibility is dependent on multiple factors. So it's not like, hey, at this place, what's the waiting list? If you have this type of insurance, it may be one thing. If you need it in a different language, if you have transportation issues. So there's a variety of things that go into it, but just like we talked about with the opioids, we want to keep getting better at being able to share that information.
Let us know.
Also
Question
say,
we've struggled with for years yet.
oh no, I would also say that we need more behavioral health organizations that accept Medicaid, provide sliding fee scales, and do other kind of help financially, because these services are very expensive.
Yes, okay.
Madam Chair,
Yes, Mr. Tepe.
Steppy here. I'd like to expand upon some points that Ms. Lewis made. I cannot be more complimentary about the effect of this particular program. One of the things is that when people have a need, it's seldom that need can necessarily be satisfied by one agency.
Right.
So this particular system has enabled those agencies to be able to comfortably refer people to other agencies. So it's not only done a better job of delivering services, to the people that need it, it's also spurred a cooperation between the organizations. So they've gotten to know each other better. And you can see by this diagram or this whole listing that was just passed out, that it's a myriad of agencies that are available, and just understanding what those agencies can do can be a daunting experience. So by having this IRIS system and making it work, this has just been such a tremendous advantage for everybody in this county. And I really want to applaud, not only the work that Kim is doing, but also the leadership that Michael has given in this particular area and the rest of the health department. It's really phenomenal.
Absolutely. Collaboration at its best. Any other questions for Ms.
Exciting,
Peterson?
as you can tell, I'm very excited about it. And this guide, we have these guides available. We just did an update and reprint. So all the organizations in where their phone numbers are purple are those that are participating in IRIS currently. This isn't an exhaustive list of everything that we have on IRIS or even in the community, because it's more child and family centered. But please feel free, if you'd like to hand these out to organizations or just have any questions about them, email me, let me know. And we have this QR code on the back that will take you to our AOK website, which is where that video is located, under our IRIS initiative page.
Did everybody get one of these?
No,
Okay.
No, we didn't because we were.
Okay, I'll give you guys one. no
Okay.
problem.
Yeah, it's great. Okay, any other questions?
Madam
Thank you so
Chairman,
much.
this is- Madam Chairman, this is Alan.
Yes, Miss Allen.
Thanks for letting me interrupt your meeting. Is there any chance that brochure could be put in our mailboxes?
Yes, I'm
Absolutely.
getting the nod from Michael and from Kim. Yes, they'll be in your
Yes.
mailboxes.
That's great. The other thing I wanted to say was just an anecdote. When Barb Jeffers was still heading up the department, I attended a meeting over at Delnor with Mr. Isaacson and a number of partners, and he was talking about this new system, and you could just see people rolling their eyes. Here's the government. Here's another thing. Yeah, that's going to help us. Yeah, it's another form I have to fill out. So what's so wonderful is that in fact, this is a tool that does work and does help. And as people figured that out, it has become more successful, and I expect it will continue that way. So it's just kind of fun to see that something that showed up a couple of years ago has blossomed. So thank you for your work, Mr. Isaacson and Kim. This is terrific stuff. Thank you.
Thank you. You wouldn't believe how many people came up to me and said, this won't work. Just stop now. And myself and my coworker, Anna, were like, no, we've been social workers. This would have changed our life if we had this back when we were doing direct service. So we're not going to stop. If we fail, we fail, but we're not going to stop. So
You have absolutely earned bragging rights for sure. Okay. We do have a proposal a resolution this morning. Mr. Isaacson, you want to talk about that?
Sure. So I believe the first one is looking at our I do have the agenda, is looking at a new contract for us for interpretation and translating. So a little background on this. Just about a year ago, we were looking at how we could add video so that we could have sign language at some of our clinics. And through that process, we were working with the state's attorney's office, and our vendor at the time had some indemnification language in the contract to be able to add those services. So in coordination with the state's attorney's office, we said, well, why don't we go out to bid and see what we can come up with? So we actually put together a request for proposals, had, I believe, was it 12 organizations responded to that. We started with the three that met our needs, that were the lowest bids. We've identified this organization called Propio, which really does excellent work. And we're also working with a company called Metopio. So I always have to double check to make sure it's the right one. So Propio for translating. But lo and behold, they also have the same indemnification language. So we have all of our agreements reviewed by the state's attorney's office. In consultation with them, they said it's fine to move forward with this, but because of this language, it's going to require the county board to vote on it to approve it. So they said they don't view this as a high risk situation, but that it would require board action for us to move forward. So just a little background, this will give us interpreting and translating. It does have the ability where we can use iPads and have video interpreting, which is much better, but also the ability to do sign language if people need that. So we view this as a very positive improvement for us, and are just simply seeking your blessing because of this indemnification piece. And I'm sure somebody there, the state's attorney at the county board level or at executive committee can answer any questions. But I made sure, I said, before we go to the committee, I want to make sure that nobody comes and says we shouldn't do this. And they said, no, that's not what we're saying at all. You just need this approval.
So does everybody understand he's asking for a blessing in this committee to move it forward to the county board? So do we all agree?
Second, Williams.
There we go. All right, thank you.
You have to call the roll.
Juby,
Juby, aye.
Silva,
Silva, yes.
Tarver,
Carver, yes.
Williams,
Williams, yes.
Young, Sanchez, Strathman,
Strathman, yes.
passes.
You. And then we have another resolution.
Excellent. So the second one is for the grant that you approved last month, which is the new $300,000 grant that we just received from the National Association of City and County Health Officials. Again, we were one of 5 health departments in the nation selected to participate in this program. This is us working with our hospital emergency rooms to actually embed peer recovery specialists so that if somebody comes in with a substance use issue or after an overdose, we can better link them with services, hopefully, so that we can get people into treatment. So this grant formally starts on February 1st. You approved us accepting the grant. Now this is providing the financial information in terms of how we're going to spend the funding. There's a portion of it that the health department will use internally for salaries. And then the majority of the funding is going to be used to actually place these individuals in the hospitals and work with the hospitals on data tracking and things like that. Bless you. So this is just further detail to authorize us to expend these funds.
Okay, I'd like to move in a second, please.
Tim's motion.
Who's moves? Do I have a second?
Tarver seconds.
Thank you. Take the vote.
Juby,
Juby, aye.
Silva,
Silva, yes.
Tarver,
Tarver, yes.
Williams,
Williams, yes.
Young,
He dropped off the call.
Sanchez, Strathman,
Strathman, yes.
passes.
Okay. Anything else for you this morning, Mr.?
No, thank you for all of your support. I've been talking to people and the support that we have to really make an impact over the next couple of years, I'm really excited about. So thank you for being so interested and asking such good questions and being such great partners.
Thank you. Thank you. Now, our next show, our animal control.
Good morning, everyone. Our reports are on file. We don't have much this month. We are currently working on our dates for the fiscal year 23 vaccine clinic. That's coming up starting in April, so I hope to have those to you by next month. Other than that, we're still dealing with our high population, hoping to get those numbers down. But it is what it is across the nation right now, so we'll continue to work with that. If anybody has questions, I am always here and available for anyone.
Madam
Any
Chair,
questions? Yes, Ms.
I
Cox.
just wanted to apologize. I got COVID literally when I was coming to pick up the, I think it was Odin
Mhm.
was there. I was gonna come and grab him for the holiday, but I got COVID, so.
No,
Remember we talked
understandable.
about that holiday
Yes.
thing? Yeah.
Madam Chair,
Yes, Ms.
I,
Bates.
I keep telling her the dogs don't know it's Christmas, but she doesn't believe me, so.
I would
They
add
have
to
a
that,
stocking.
it's not too late. It's not too late.
Yeah.
Oh,
Commissioner.
yes, Dr. Silva, was a host.
I am actually fostering one myself, so I encourage all my fellow board members to lend a hand wherever they can, and that's one way to do it. So it's not too late.
We can all be helpers.
Exactly. Yes, we can.
Okay, thank you. Okay, anything else?
That's all I have.
Okay, thank you.
Thank you.
Do we have any old business this morning? Okay, I'd like to have the reports placed on file. I don't think we have any need for an executive session.
Do we need a motion on the reports?
Okay, I forgot to take the roll call on putting the reports on file.
I'll make the motion.
Thank you. Second,
Tarver seconds.
thank you. Mr. Tarver?
Juby,
Juby, aye.
Silva, Ms. Silva, Tarver,
Tarver, yes.
Williams,
Williams, yes.
Young, Sanchez, Strathman,
Yes,
approved.
Silva, yes.
thank you, Ms. Silva. Okay, do we have any new business? Had lots of new information this morning, lots of great stuff going on. Thank you, everybody. So I'd like to have a move to adjourn.
Motion.
Any second?
Tarver seconds.
Okay, thank you, Mr. Tarver. Thought people wanted to stay. Continue these great discussions. Thank you.